Today we are going to address a very uncomfortable but vital topic, our own mental health. Intensive care takes an emotional and physical toll, and with the age we realize this more. And in the last few months we have been witnessing a major increase in the number of suicides and mental health issues amongst our colleagues. To address these important issues, we have the session today. The first keynote session will be from Dr. Alok Bajpai, followed by a panel discussion. I'll hand over to our chairpersons, Dr. Sunil Karan from Manipal Hospital, Bangalore, and Dr. Shikha from Regency Hospital, Kanpur. Over to chairpersons.
Thank you, Dr. Yash. I welcome all of you and my co-host, Dr. Shikha. This is the series of panel discussions and webinars that's been spearheaded by the IICCM. Thank the IICCM leadership for sort of organizing this very vital interactive platform, and also, of course, the leadership for choosing this fantastic topic. There's a lot that we can discuss over the last 1 hour. I think, of course, for constraints in time, we will get on the job straight away. The initial keynote address, as already mentioned by Dr. Yash, will be taken by Dr. Alok Bajpai. He's a senior consultant at Regency Kanpur, extremely accomplished and a very, very sort of clinical as well as a research-based psychiatrist who has a very strong root in Bangalore, is what I just came to know prior to the talk. Welcome, sir. And without wasting much time, I would hand over the platform to you, sir. We are very keen to hear you and learn from you how to keep ourselves healthy mentally, physically, and of course, psychologically as well. Over to you, sir.
Thank you very much. Thank you, Shikha, and thank you, Yash, for giving me this opportunity. Even if it is online, that's all right. When Shikha messaged me, and you messaged me the document about mental health, I thought that often when doctors meet and they are talking about medical issues or even in conferences, we are by our training normally used to talking about data and about the lot of vocabulary which we normally use in our research and when talking about serious academic things. So I thought, let me talk it differently, because amidst all this academic type of discussions, we actually never sit down together. On our own, we often do this, or when there is a crisis, we do it. Together, we never sit down to peep deeper. Right? Like, let me give you an example. If you talk about mental health, and just type, say, about mental health amongst doctors, or you type mental health amongst critical care physicians or intensivists, I'll tell you a few words which will come up. Burnout, suicide, care of the caregivers, communication, mindfulness, right? Depression, anxiety, of course, all that we know very well. But these, if you just type, you'll get millions of papers on that. So if we can, as a rigmarole, talk about it and reach nowhere. So I thought, let us do it differently in whatever 10-15 minutes we have. And then obviously with panel and questions, and Aleem is here and Chinu is there, and we can go as deep as we want. But as a habit, we should talk about statistics first. Whether there is some real mental health issue at all. As I talk to my psychiatrist friend, I often tell them, is there some real mental health issue, or is it a hoax? Or is it that because there are too many psychologists and counselors and doctors around, we keep talking about it? Anyway, that apart, if you just do a rough analysis, the range of mental health issues in various studies in India or abroad, I mean, the data ranges from 22% to 46%. If we broadly take mental health issues, which includes depression and burnout and anxieties and suicide or drug addiction uh, and then you will find more of it in anesthesia people, which most of you would be, pulmonologists and pediatricians, and then so on and so forth. But then a critical care unit is not only about doctors. It is also about the nurses. It's also about the staff. So when you just scan the incidence rate in nursing staff, that goes to a staggering 70%. So from this range of 22 to 46 in doctors, goes up to some roughly around 50 to 70% in nurses, with frank diagnosis of depression and anxiety and all that. So we leave apart this clinical labels. Let's look into the reasons, because obviously there are two types of interventions. One, there's a problem, you handle it, you send it to a psychiatrist or a psychologist, get it treated and in an individual, and people improve, people don't improve, all that variation happens. But I think what we should try to do is, so maybe there are a lot of more questions at the end of my talk, but I would like to point out something else. In first place, so given that doctors are also human beings, they are as prone to having mental health issues as anybody else, because they may be trained in handling mind and body, but their life does not give them a reprieve. Their life does not give them a privilege key. You will have no problem in your life and you can carry along. You'll have problems in life. All of us have. And the coping mechanisms are the same because the neuroscience is the same. We may learn a certain, so it's like a soldier. A soldier can fire and kill, but nothing prevents him from getting a bullet in his head and getting killed. He'll die when he gets a bullet. It's the same with us. We may be treating a lot of stuff, but all of us can, psychiatrists can fall ill and have mental health issues. They do have, we know it very well. And a cardiologist can die by a heart attack. Cardiac surgeon can die without help. A neurosurgeon, neurologist can have a stroke. All that happens because that is nature. We are trained in certain things. So in a place like a critical care unit, what is it that gives us such high level of, even 22% is high, and 46% is definitely high, and 70% is higher. So when I'm talking about it, I'm talking about your unit per se and not only doctors. So what happens in a ICU or a critical care unit? Why is it that such level of stress, I mean, stress can happen anywhere to anybody. And I think a cardiac surgeon also has a stress, because one small mistakes and things can go awry. A neurosurgeon has it. People think psychiatrists don't have it, but they have a different type of stress. People often treat us as dustbins, bringing in all their baggage. And any psychiatrist and psychologist will say, so the type of stress may change, but the stress is there. What is happening in your critical care unit? And I think there are few things which you all know it. I'll just reiterate and maybe then we can try to link it all. One, the morbidity level in critical care unit is very high. And I'm not talking of mortality at all, because mortality obviously is high and you know the statistics better than me. But even if you keep apart the mortality part of it, the morbidity is very high. You are in an enclosed space. The units are obviously enclosed for a major part of the day, and what you are seeing all the time. And if you are a critical care specialist in a critical care unit, I'm not talking about the doctors who come and visit and go for 15 minutes or 20 minutes just to see their patient. But as specialists, you are in an enclosed space and all around you is morbidity. All around you are people who are really critically ill and with a good amount of probability of not improving. Even if it is 50%, there's a big chunk, which a physician doesn't face. A physician sitting in a clinic and prescribing medicine, there's a lot of hope there. Hope in a sense that, okay, you give medicine, patient goes home, and going home and being okay itself is a big hope. Yours is a battle against hope. In fact, if you look at it deeper, you may be able to save people. There are a lot of people who improve. There are a lot of lives are saved. But still, when you start treatment, anybody who is wheeled into a critical care unit is critically ill. Right? It's almost on the borderland of surviving and not surviving in most cases. And then with treatment, people improve. So one, this continuous interface with morbidity, that whether there are no ways of calculating that, but trust me, whatever goes into a human head from your senses leaves the impact. And with every second, the brain itself is organizing its memory, its emotional status against all the influence which is coming in. So one, the heavy stress of a critical care specialist in a closed unit is this continuous exposure to morbidity. The second is, see, we all human beings survive together. That is the evolutionary pressure on us. By evolution itself, we can't live alone. One is the fear of death, which is universal in all of us. And one is the fear of being left alone. And these two fears motivate most of the stuff which we do. So imagine, think in reverse. We may be very, very objective in our approach, or we may think that we are very objective. We may think that, no, I know how to treat, and I'm not very, very emotionally attached to the patients, because half the patients are on ventilator or BiPAP or being sedated or seriously medically ill. So I am not attached to the person. But this is not true. The truth is, when you're continuously seeing such people, there is a certain biological empathy in our heads. The whole area of insula and anterior cingulate gyrus and medial prefrontal lobe, they are meant to giving us meaning to our emotions. So we may not be very, very overtly emotional, but each such patient leaves a mark. And that is why when patient has improved and it wheels out, you get a sense of relief, don't you? Do you feel a sigh of relief when the patient is wheeled out safely and you have saved the person? We all do. We all do. Why? If you are so objective, neither should you become sad and nor should you become happy when the patient is improved. But this is not the case. So we count our happiness and relief when the person is wheeled out safely. But what we don't count is that when the person is continuously ill, the amount of empathetic stress which is seeping into your head. And if you're working 10, 12 hours, so you can calculate it. There must be exponential increase in all that. So one is morbidity, second is this empathy. And third, the face of death is staring in critical care units much more than on a cardiac surgery or neurosurgery table. It is just staring you. And you are at the helm of affairs, where your decision making, and decision making, we all know, actually happens in split seconds. Whatever knowledge we may have accrued, whatever, but our decision is, even the most rational of decision, at times can have a subjective core. It can have an emotional core. Unfortunately, we doctors, throughout our training, right from day one of medical school, I don't know any medical school in this country, at least holding back their students and teaching them about empathy or teaching them about decision making. We assume that this is how it happens and this is how you should decide. And our algorithm and heuristic process in the brain tends to decide the same algorithm which AI is trying to copy, or AI is being trained to do that. But the decision making is weighed by all these things, by your emotional state, by your continuous exposure to, and then the fourth point, which is very important, a lot of this stuff becomes mechanical. Even every patient is a challenge, but often 70% of the work is mechanical, the way you do it and the way. And the same component works with nurses also, who have to carry out orders. So your personal baggage, which is a very, very subconscious and unconscious level, overtly we all are trying to act very objective, decision making, sort of detached, but all this is working inside. And that brings out your interface with the nursing staff and other staff in the way we communicate. So when there are immediate decisions to be taken, people get very worked up. There's a lot of shouting, this, that going on, and somebody will do a mistake and you have to correct that because you obviously you don't want to take a wrong decision. All this has a cost. Even if it's a very small, with each patient, even if it is a very, very small part of it, but then if you multiply this over time, the number of patients you see, a number of losses we have, add to it your own baggage of life, it becomes very, very formidable. And that is the point when burnouts start happening. When people start getting bored of the job. So either they start taking it casually and then frequent mistakes, or at points of time, if suppose you're clustered with a lot of losses and failed treatment, and then you start questioning ourselves. Obviously leading to depression, anxiety, and loss of confidence and all. This is the undercurrent of everything. And in that sense, you all people are exposed to stress much more than anybody who's sitting in a clinic. Because clinic has an advantage. You may be stressed for an individual patient, but then every 10 minutes, 15 minutes, people are changing. They may be coming with the same story. People are changing. There is a lot of external interface. Your interface itself is limited. And then something which I'm going to say, which people agree or may not agree. But one fact is people do things for money or fame. That is we may be doing a service, but then one essential side quest of medical science is money, fame, all that. So money, obviously you earn. Fame also you earn. But then somebody who is in the critical care unit, often patients also don't know who was it. Patient's attendant would come to the ICU or wherever you are, will talk to you, but eventually the whole process will go to the treating physician or surgeon or whoever it is. So all this put together, so in one go, this will not cause you any stress. But accumulated over time, your own life story and your temperament can lead to issues which can be a serious mental health problem. So what are the mental health problems? First to go is your communication, your mood, your interest in the patient. From this, it can lead to frank depression, to alcohol abuse. This is very common. And in some cases, extreme cases, suicide. See, these extreme cases of suicide or self-harm behavior, most people, arises when people tend to lose meaning in their life. And trust me, anything can push you to that. Anything. You are having a meaning in certain thing, and suddenly you realize that this is all futile. That is the point where people take drastic steps and get into drugs or alcohol or any type of deliberate self-harm or suicide. Now, what to do with it? What to do with it? I think one way is that you intervene when there is a crisis. The second way is you do some regular stuff by which you get, it's like a pressure cooker's cap. You keep releasing the steam. And at a collective level and an individual level, both. Because if you become all right, you can handle your stress, and 10 people around you are not able to handle stress, there's no point. That will become a very, very useless exercise. So everything, all critical care units should have outlets, psychological outlets. Individually, people can have definite working time, go back, shut off from their mind what is happening, get into exercise regime, to music, to meditation, to whatever you feel like, partying, and people do various things, but that may be your individual effort. At a collective level, I think what people should devise is brainstorming sessions and include your nursing staff in that. Include the cleaner, the other employees, and let them talk. Let them talk. Talking helps. If they bring out their stress, I'm sure everybody in that group would have handled the stress somewhere or the other. People can share, people can empathize, people can, suppose a person X has handled a situation of getting bored.
Sorry to intervene,
Yes.
sir.
Yes.
Another 2 minutes we
Yes,
have.
yes. I'll wrap up.
Thank you, sir. Thank you.
So this collective exercise, like a brainstorming or empathetic meeting, is a must. Doctors can do it separately, maybe once a week to audit and all. Do it with the nursing staff because they are your support. Sometimes I joke, doctors are very stressed. And if they listen to nurses, they'll feel better. Because nurses are more stressed than us. We can give our order and turn back to our mobiles. They have to carry it along. But I think they're much more better equipped in handling it then and there. So this collective hand holding, I call it hand holding. Hand holding is very important in the setups like critical care units. Because then when it comes, when you get bored, or when you get tired, or when you feel there is no meaning, when the futility appears, there's always be somebody to hold you, give you rest, and put it back to you. At an individual level, obviously, there is no universal mantra. Everybody has their own way. So that you will have to devise, and obviously, sometimes it can boil down to a clinical level. For that, psychiatrists and psychologists, they are there, and medical treatment is there, and psychotherapy is there. But I guess if you get down to these basic things of finding meaning and not getting into this hopelessness trap, and a lot of these mental health issues which are reflected in the studies will get over. So it's like a family which has to hold hand and help people. So I'll end with this. Obviously, there'll be a lot more discussions, but then thank you very much.
Thank you, sir, for such a wonderful sort of insight into the daily problems and making it so simple. In fact, I think it was good not to have slides because we could give our full attention to hear you, sir. Right, sir. Sir, we will take the questions after the
Yes,
panel.
please. Yes, please.
We will just because some of
Sure,
the
sure.
questions that they may have might have been
Okay.
answered in the
Overlap.
panel as well. Yeah.
Yeah. Yeah.
So I would next hand over the platform to Dr. Shika to introduce the panelists, which will be on breaking the silence and how to build support systems for intensivists, which in many ways pragmatically sir has already mentioned. And I think given us a lot of sort of day-to-day tips on how to handle it and emphasizing particularly the team building concepts. But I think we learn more from our expert panelists. Dr. Shika, over to you, please.
Uh, Thank you, sir, and thank you, Dr. Alok, for such an insightful talk. It was rather more of a conversation. Uh, it was very happy to hear to you as always. Now we'll be moving on to a panel discussion, which where we'll be addressing the key mental health concerns and factors that lead to active suicide and rather passive suicide, let me say, in in people who are working in critical care, and what are the reasons behind such a heavy toll. So the moderator for the same is Dr. Yash Javeri, of course, who is a director CCM and emergency medicine at Regency Healthcare, and he's also the vice president of ISCCM and general secretary SNCC. In among the panelists, we have a mixed bunch. We have Professor Aleen Siddiqui, who is head of department psychiatry at Era Medical College. Then we have Dr. Chinu Agarwal, who's a very eminent psychologist and psychotherapist from Agra. We
Right.
have Dr. Vignesh Vasudevan, who is a critical care consultant from Ramakrishna Medical Center, Trichy.
Welcome.
Dr. Pankaj Kumar is here with us. He is Director Critical Care Medicine with Fortis Shalimar Bagh, New Delhi. And we have Saurabh Kole, Dr. Saurabh Kole, again, who is a very, very senior intensivist from Kolkata. So I'm quite sure there is going to be a very eclectic and insightful panel discussion. And over to you, Dr. Yash.
Thank you. Thank you, Dr. Shikha. Thank you, IACCM leadership, for the opportunity. Thanks all the panelists for joining us. We'll try to keep the solution simple as Dr. Bajpayee sir has already pointed out. Let us be very simple and avoid jargons. I will start with our guest faculty, Dr. Aleem and Dr. Chinu first. Dr. Aleem, what are the barriers to seeking help amongst doctors, especially when they have serious mental issues like a suicidal tendency?
Yeah, thank you, Dr. Yash, for inviting me and the whole team. My pleasure and my respect to all of you because all of you intensivists are already saving our lives. So thank you so much. Regarding the barriers, I would say a lot of barriers could be there. Now, first barrier would be when we entered the medical field, what did we learn? That we have to study, even if your back is aching, if your head is not there, headache is there, so you have to just go on, carry on. So we have been trained in such a way that you do not talk about stress. You talk about stress is there, but you have to do it. So after that, we entered into the field and then we got here. So I think this barrier starts from there. If I'm talking for a doctors as specific, so we are trained for carrying on with the stress, carrying on with the work. The show must go on. So that sort of thing. That one thing is there. Now, other thing in general is we all know stigma because many of my patients when they meet they say sir ये मत बताइए कि दवा चल रही है, we are just friends. So this stigma is one of the barrier. Now career concerns, if you talk about your mental health issues, the institute policies, if they are not very open or aligned, the person gets into trouble. So that no, bhaiya, you are a psycho patient, you are a mental patient, we can't trust you. So this sort of misinformation causes the stigma to rise. Then there are cultural norms that you are doctor, so you should cure yourself. Doctor hai to बीमार काहे को पढ़ रहे हैं? So that is one issue. Another thing is one of the most important things is time constraint. You don't have the luxury of choosing your patient intervention time. It has to be done when it has to be done. The patient cannot wait. It has to be there, and you have to be at your full alertness. And so it can be back to back. There can be gap in between. So all these things actually cause barrier to seeking mental health issues. So I think if you're able to take care of these barriers, we'll be more involved in our mental health would be better. Back to you,
Thank you,
sir.
Dr. Ali. Thank you. Thank you.
Thank you. I would like to just add one more point that there is a sense of self-efficacy which makes us feel कि मैं कर लूंगा डील. हो सकता है कि हो रहा है कुछ प्रॉब्लम, but I think that I'll be able to deal it. If not today, maybe by tomorrow I'll be better. And this sense keeps us just linger on with those thoughts, with those ideations. And the fact of the matter is that 75% of suicides are by men. And they take it to completion even before knowing that they are going to complete the suicide. And even till the last moment, they are feeling that they'll be able to avert it themselves. But it doesn't happen like that. And as Dr. Alok sir said, rightly said, talking helps. If there is a very famous suicidologist, his name is Dr. Edwin Snedman, who says that, people always talk to someone or the other directly or indirectly about what they are feeling, but they don't pursue that talk themselves. They're looking at others. कौन मेरी सुन रहा है? Am I even visible? क्या कोई मुझे सुन के मेरे साथ परस्यू करेगा, कोई मेरी केयर करेगा? और वहां पर वो हेल्प सीकिंग बिहेवियर अगर किसी ने जरा सा कहीं किसी को हिंट दे भी दिया, उसके बाद चुप हो जाते हैं. Then they keep expecting that someone will come in front and say कि भाई क्या बात है, बताओ. बट कोई आता नहीं है, तो फिर वो वहीं स्टॉप हो जाती.
Thank you, Dr. Chino and Dr. Ali. Thanks for those vital information. I'll move on to Dr. Pankaj, sir. We need to take care of our herd, as Dr. Bajpayee also pointed out. We often miss on that. We do not have a buddy system. At times, we are bullying our juniors, and the culture has to be blamed in totality. So how will you suggest, how do we improve as a critical care department in taking care of our own selves and our colleagues, juniors, fresh trainees, fresh nurses? Because everyone has to work. A fresh nurse, ICU nurse, she has to start somewhere. And we don't like fresh nurses or the fresh MOs in the ICU, but somewhere they have to start their life. So what is your take, Dr. Pankaj, sir?
Yeah, thank you, Yash.
Sir.
See, ICU is a very, very challenging environment, and we all know that doctors or nursing, they need very intense level of personal and emotional contact with the patients. This becomes more complex, more challenging in today's time when medical as well as legal complexities are there. I am especially stressing this point because there is always a fear of in legal trouble and all these things. So a good environment is what you are asking is a very, very in such a stressful situation, the most helpful thing is the peer sport. If we don't support each other, nobody is going to do it. Nobody else, not even sometimes not even colleagues from other departments. So one of the best thing which we can do is to have a very, very good relationship among our colleagues, at least in ICU. It is desirable that all departments should be, doing a very cordial atmosphere with each other, but it's not always possible. So in ICU, it comes on to senior people that how you make a good environment for each other, a sporting environment. So as Dr. Vajpayee already has suggested that take nurses also. It's a very valid point actually. Problem is I was reading one of the studies regarding this only. The burnout and all the stress issues are more in nurses, more in females. Another thing which we have to do is their work-life balance. That is one of the factors of frustration because as a females, the work-life balance is very, very difficult to maintain. So that's why possibly females are more prone to this thing. So it should come from the organization as a organizational policy to make a good and cordial atmosphere in the ICU. Especially, we should think about the working hours also. One of the problem in ICU is the working hours. So this is the third point that we have to give them time enough to relax themselves. A person can relax in anything. It's a personal choice. Somebody can see films, can do exercise, whatever, but then time has to be there. They have to maintain a work-life balance, self-relaxation time, and that has to be provided by the department and the organization. That is the most important thing which we can do from, of course, parties and all things goes now, but a comfortable working atmosphere. And another thing is that when we look at our juniors, sometimes they are making mistakes. Now, if we scold them or some places they even check out of the work also, but they may be having problem of stress or burnout. So we have to recognize it. And second, another important thing is that all the hospitals, and if not hospitals, then our society can take a lead in making a system of sport. I was reading about a system RISE that is the most most widely accepted system in the world by the Johns Hopkins University, accepted in 140 health centers. That is resilience in stress times, and it is a peer sport group. At least if there is a system, then only people will approach it. First, there should be a system, and second thing is that people should have a faith in that system. That if I go to them, I will take a stigma also, and then there's no help, then people will not come. So a system which is credible, either by our organizations or our society can take a lead. I am very happy that lecture is being taken. In my book also, I have a chapter about work-life balance about nurses, a story, in fact, it is a story book. So I am already aware of this problem. So I think society can take a lead. We have in every city, we have organized society branches. They can well aware of the local problems of the. I will add one more thing in our this thing, the harassment part, which is not discussed. Our society has different kind of problems, you know. Last year also one lady doctor did a suicide in Rajasthan. So these are systemic harassments. So that thing can be taken care by the local bodies and they are aware about the local problems. That's what I have to say. Thank you very much.
Yeah, thank you, sir. Thank you. I'll move on to Dr. Saurabh Kole. Dr. Kole, sir?
Yes, yes.
Yeah. You have done a lot of good work during COVID and after COVID, and you made a COVID memorial park also in Kolkata for the doctors who succumbed to COVID. How do we build team resilience and how can we take good care of our own team, especially avoiding compassion fatigue? And there is no culture of a huddle after a major mishap in the ICU, after a sudden death, sudden poor outcome in the ICU, as we do for code blues, debriefing. What is your take on debriefing and compassion fatigue in our ICUs?
So actually, this debriefing and compassionate ideas, I should say that it should reach to the people first. That whenever we are doing something, that outcome, what is the outcome? I am giving you a simple example. We know that when the dengue fever, dengue shock, these patients were treating earlier, So whenever this platelet count below 1 lakh, below 70,000, initially we are giving that platelet also. But whenever the guideline came that if it is below 10,000 and if it is associated or with other breathing problems, then only you can give this platelet. So similarly, what are the outcomes of different issues what we are taking that the people doesn't know. So that's a continuous process, and obviously some institutional policies should also be there. We should make in some wellness programs and the mental health resources. We can provide access to the mental health professionals. Whatever I have listened to Dr. Bajpayee, it's really a great thing to us. So this is very much important, and also some sort of flexible work arrangements. And many a time this is the duties are to be flexible, and burnout prevention training provide there's burnout prevention, state management, etc. This is also immense importance, and actually the ICU in charge also can play a major role that they to get their problems, etc. and they can try to solve out accordingly. So whenever you utter the name of COVID, actually say, you all know that 2,000 doctors died during that COVID. But you see, at that time, the respect what we are getting during COVID time, now it is genuine, gradually it has come down. So we are going to the same situation. Many a time we found that the harassment is there. So actually, what I feel that the society also, whenever such thing happens, say for the COVID martyrs, I should say, they are the martyrs, because at that time the doctors, they have worked there without having any proper instruments, without having any proper medicines. They tried, and you see that how much importance the society has given. Okay, initially at that time it was given much more importance, but now the things are gradually coming down. So we the doctors also should take initiatives that whenever any doctor do some good work, and we should try to respect him, we should try to acknowledge him. And actually you see that whenever the health becomes a commodity now, the pressure is there, much pressure is there. So we'll have to work some pro-people activities. We have to work with the common people. Because you see you know that whenever you are thinking of that this medical colleges, there's so many medical colleges are coming, and you all know that what is the standard of those medical colleges. So all these actually these are the problems with this burnt out syndrome, and many people are doing suicide now.
Thank you, sir. Thank you, Dr. Kole, for bringing it out. I'll move on to the youngest participant in the group. At least he looks youngest. I don't know what is his age. So, Dr. Vignesh, probably you are relatively new in the field, and we all understand intensive care professionals by virtue of their training. They are very intense, most of us, and it takes a while. At least we are in 40s or 50s, or probably someone might take longer to have some calmness in stressful situations. How do you achieve a professional balance in the ICU, and how do you achieve work-life balance? Because this is very, very important to avoid burnout. Peaceful workplace and a balanced work life.
Thank you, sir. Before starting, I want to congratulate the ISCCM body for choosing this topic. Just the fact that last 45 minutes we're all discussing the challenges faced by the intensivists. I'm feeling heard, I'm feeling supported, I'm feeling much relieved just by the fact that we're discussing the difficulties. Thanks to Dr. Bajpayee sir, Dr. Aleem sir, and all the people here. Excellent discussion so far, sir. Coming to the reality and the challenges which we face, every doctor wants to save the patient. And in the current practice, we're all target-oriented, outcome-oriented, rather than process-oriented. So everyone wants to save all the patients. And the fact that we face with really sick patients, who some of them are salvageable, some of them are non-salvageable, which we really understand after a few years of ICU experience. But by the fact that when we try to explain this to attenders, they'll be just awestruck. They'll be thinking, I'm in the best ICU, best hospital, I'm spending so much. You are the doctor. Why do you say you can't save? Why can't you save? So that's the question which usually comes. So we all understand it's high adrenaline situation most of the time and extensive work shifts. So how do we do work balance? So really tough question. Theoretically, we can say a lot of things, but in practice, I don't know. Maybe Yash, doctors, the senior intensives here may be practicing. I found it difficult in my initial years, but now I'm struggling. I did struggle a lot, and I'm very much relieved after this session, like hearing to such senior doctors. What I think can be done is maybe we should get the necessary off period of the work, get the necessary sleep, get the nutritious diet, get follow a routine, have a discipline, try to focus on first physical health, then if possible mental health, seek support like the wonderful doctors here, Dr. Bajpai, Dr. Aleem sir, get support and make sure you're not alone. Try to approach your seniors, seek for help. I was taught right from the beginning of my medical training, whenever you're in doubt and whenever you're struggling or you're alone, just seek for help, discuss with your seniors, because I know Dr. Yash must have heard hundreds of challenges, which I'm saying now. So I think we should seek for help. We should be open. We should accept that there is a problem. Number two, try to resolve by getting help, sir. Over to you, sir. Accept so far.
Wonderful, wonderful, very practical points. First of all, acknowledge the problem and the person or the colleagues. See, the people we meet day and out. Suppose Dr. Shikha and we are in the same team. Suppose we are meeting daily. We will read from the face, oh, you are not looking okay. Is there an issue? So we need to have this concern and empathy to our colleagues first, then to others. And there was a very good culture of departmental picnics everywhere in the country, and those are family picnics. We made very good bonding with each other. That has disappeared, and in the race of money and whatnot, we have lost many good things from the practice of medicine. Another important point Dr. Vignesh highlighted is disengagement after debriefing. Two things. Do not take the outside stress to the ICU, the home or whatever, the car race, you lost money. Don't take it to the ICU and don't take the stress out of the ICU to your home. So you have to disengage. When you do your handover debriefing, you have to disengage. Do not take that baggage. It is very difficult, and most of us with continuous vitals coming in, tele ICU and whatnot, we have added another baggage to our head. So we have to disengage at some point. Trust the person who is on the ground so that you attain some mental peace. We'll move on to the next topic, Dr. Chinu.
I have 30 seconds, sir. Can I say one point?
Yeah,
Just
please.
There are also the culture of this audit meetings, sir. We conduct near miss audits, mortality audits. Some places they criticize, they pinpoint, they say this was you did wrong. Some places I really appreciate, they do constructive criticism, sir. They train the trainees in which way it will not happen again. I would recommend some constructive criticisms which will help in the near future. Over to you, sir. Excellent, sir. Thank you.
Very valid point. Dr. Vinesh, first point, very important point. We are not gods, and the destiny is already done. We try our level best. The outcome is not in our hands. What we tell to the family, and the outcome depends on the context. If I am in a periphery of, say, Tamil Nadu, near Chengalpattu, the outcome will be obviously different than I am at Apollo Chennai. So periphery depends on the context. Another important thing, what intensivists are developing a habit of, they take the whole garbage on their head. No, you are not the owner of the hospital, you are not the administrator of the hospital, you are not the service server of the patient. Patients are passengers, they will land up with you or someone else. So don't engage your heart and brain. Yes, you put your heart and brain into patients, but don't get emotionally attached too much. That will give you an emotional injury every time you have a bad outcome. So the outcome depends on many things. The same patient you might discharge from the ICU, and after 2 days the patient will come back. The whole purpose of mortality and morbidity meetings and all these audit meetings is not penalizing. It should not be punitive. It should bring out new learning which should be implemented. Sadly, in most of the hospitals there are no new learnings. The real stakeholders of mortality meeting don't come to the meetings. That is a different story. We'll avoid that. But as an intensivist, We should make it a habit that we are not responsible for each and everything in the hospital. We are responsible for our own area and the outcomes in our own area, not for the hospital or the post ICU discharge. We move on to the next question. Dr. Chinu Agarwal. Somehow, despite so much of odds and so much of talks about mental health, we still lack structured support. Even best of the corporate hospitals countrywide, we do not talk about mental health for professionals, our own colleagues. How to improvise that, and what is your take on that? And I'll request Dr. Aneem and Dr. Bajpayee sir also to briefly touch
Yeah.
on this.
Dr. Yash, if you would allow, I will
Yeah.
just first summarize the discussion that
Yeah,
happened.
please.
And the topic is caring for the caregivers. And so I'll use the word care for summarizing. So C for colleagues, peer support. And maybe we can keep this care mnemonic on the ICUs somewhere where we say that C is for colleague. Did you ask someone that, how are you today? Then second A stands for admin support or institutional support, where we can point out, because our topic today is breaking the silence. So maybe we can say that, today I had flexible hours and I'm feeling happy. Something that the admin did good. And as Dr. Vignesh just said, building a culture of appreciation goes a long way in restoring and keeping us mentally and emotionally healthy. Then R, as Dr. Pankaj said, resilience building. Resilience building is not having a false sense of self-efficacy, but actually learning to take care of yourselves. And that also answers your question that when we talk about mental health, we automatically think that something is wrong with us. But the fact of the matter is, we all have mental health, and we can't deny that. As Dr. Bajpayee in his initial talk mentioned that a cardiac surgeon can have a cardiac arrest. And similarly, the suicide rate among psychiatrists and psychologists is very high all over the world. So unless we have our jar full, we cannot pour out of it. So there are certain systems which we can follow and even customize to our own teams and learn. There is no harm in learning and educating ourselves. Unfortunately, mental health and emotional education is absent from our formal education, as Dr. Vajpayee pointed out, that intensivists, anesthetists, and doctors, surgeons are treated as people who are going to do this work with their hands. But no, the mind is also going to be involved. The heart is also going to be involved. The entire nervous system is also going to be involved. So maybe we can put in place some employee assistance programs जैसे corporate में होता है, वैसे some kind of programs where we are learning cognitive behavior therapy for ourselves, acceptance commitment therapy for ourselves. And maybe, if not in technical terms, some sessions of Bhagavad Gita, where in a very informal way, we can learn about Stoicism. जैसे सर बोल रहे थे डॉक्टर वाजपेयी that being objective is not so easy, where you say that I don't feel sad because my patient is going away, but then you are feeling relieved when the patient is getting better. That means it's not objectivity, it's not stoicism. So resilience building can be put in place in many, many ways. And of course, in casual engagement. So my E is engagement. Are you engaging outside your workplace in a healthier way? By not using coping strategies like substance abuse? Are you engaging with your family? Are you engaging with your friends? Are you engaging with your social support groups? Are you engaging with some books? Are you engaging with some movies? So what is it that you are engaging with? That completes my CARE. And maybe this mnemonic can be a takeaway to practically put into use and implement in our day-to-day practices in the ICU. Thank you.
Dr. Bajpayee, sir, anything to add on this? Not really. सर म्यूट हैं आप या म्यूट सर
अलीम पहले आप
Yes, sir. Yes, sir. Thank you, sir. Thank you, sir. I think I'll take a rather very simplistic and practical route. I would intensivists are hearing us. So I'd like to train all of you in a few words. When you are faced with a person who's harboring suicidal ideas, what to do? Okay. So we don't know how to handle, how to talk. So what we should do is, first thing is, this is called a gatekeeper sort of concept. Person need not you can help the person. So first is to allocate time to the person. So if you are feeling that something wrong, someone is mental health is deteriorating, so you have to allocate time. You have to have a rapport with the person. So start empathizing. Now, if you are helping others, in your time, others will help you. So that is important. So how do you talk? So you can start by sort of open-ended questions and go towards more focused questions. So you can start by feeling, do you feel unhappy and helpless nowadays? So yes or no answer could be there. Then next could be, do you feel desperate? You can escalate to, do you feel you're not able to face a day, your life is feeling like a burden. Next stage, your life is not worth living. And then you can ask, do you sometimes feel like giving up your life? So that is one of the hierarchy of questions that could be followed so that the person is able to come out with the suicidal ideas if the person is harboring. Then further questions could be, have you made any plans? How are you planning to do it? Is there any possession? Because in ICU, some of the ICU people I saw, they and the use of anesthetics to commit it. So have you considered it? So all these things, these are the simple questions, starting from very general. Are you feeling not good? Are you feeling bad? Are you feeling distressed? To not the life is not worth living. Are you thinking of planning, and do you have any plans for that? So that will elicit out the suicidal ideas most of the time. Okay, that why it should be done, because mostly the suicide is a person who is wanting to commit suicide. Uh, there is ambivalence in it. The person is in a seesaw phase, to do or not to do. So if at that critical moment वो pendulum झूल रहा था and you swing it to not doing it, so you that impulse passes. Then again, the sometimes suicidal person who is suicidal gets very rigid. So if you are able to maintain some cognitive flexibility in it, that rigidity, so then again the person is helped. And sometimes the suicide ideas are impulsive. This phenomena. So impulse is again time limited, short lasting. So my key point is, you have to have a certain set of questions. You apply at the moment, and then you have the person coming out of the suicide. And you can after that, if a person is having that, you can enlist support. You can seek the mental health professional. You can make a suicide contract. So whenever you now are feeling suicidal, you have to talk to me. You have to tell me. You have to not act out, but you have to communicate it. So suicide contract sort of thing. So I think these would be very practical things which could help all of you to become gatekeepers in avoiding suicidal behavior. Thank you, sir. Alok sir, over to you.
Yeah, thank you. I would just like to add 2 points. One, that we are living in strange times. मतलब ये सिर्फ हमारा आपका हॉस्पिटल एंड क्रिटिकल केयर से लेना देना नहीं है. Somebody was asking me that whether you can define what is the problem in these days today. When PhD students, a group of PhD students, I said I can tell you 3 words. 1, information overload. We all suffer from that, right? Second, we are living in a times of mistrust. If you compare your own childhood, and because of the information overload, everybody thinks they know. So there is a certain mistrust, especially for doctors. Like Saurabh said that after post-COVID, we are getting back to the same, where a person, the attendant enters the ICU suspecting that they are out to fleece us. This is the feeling actually, right? And third, people are having sense of entitlement. And it is not only in cities, everybody, because everybody has information, so they think that this the way they want it. The risk is that even our corporate setups are not helping in this. Because I see a problem that these days there are groups and Dr. Chino will agree, everything is being taught, how to laugh, how to parent, how to love, how to step from the left side of the bed. Nature has trained it for 4 lakh years, boss. What the hell are we talking about? The problem with all this, what we are talking, and we should be very careful in taking this message back. Suppose you go back to your admin, Shikha, you are there.
Yes, sir.
Suppose we take this story back to our admin and say, now this is what we have decided. I am sure most of the hospitals will open a committee, make you in charge of it. You will set a formal plastic environment to it and then make it very formal. It will fail. I can guarantee you it will fail. Because everybody, you are not living like an island. People are stepping out of ICUs in the world where the same mistrust, same information overload, same sense of entitlement is happening. So my suggestion is reverse actually. If you really want to do this and hold hands and all, before you make it a formal thing, get into more informal getting together. That will work more. Because even to develop trust, and even before nurses can develop a trust that Dr. Zaveri will listen to me empathetically, it will take a hell lot of time. You can't convince your spouse that she or he will agree that you are listening empathetically. In fact, most of the spouses don't agree to that. Yeah, they will say, "Arey yaar, sunta nahi hai, sunti nahi."
All of them, not most, all of them.
I'm just saying.
Yeah.
Then in your own family, ask Ali will tell you, the most people who come, youngsters will say, "Ma-baap are not listening." In the family, people are not listening. I mean, we have really gone down to what levels of belief? I don't know. So get
Sir,
it informal. Yes.
Sir, this brings a question to my mind, as you said that these committees and this system paralysis is not
Yes.
going to help us. Also, sometimes we, as doctors, we are so intelligent, we think we know the
Right,
cause
right.
and the remedy ourselves,
Oh,
and
yes.
we tend to talk it out among ourselves, but we are doctors. End of the day, we are not therapists. So when talking is just not enough, and when should we actually take a professional help? When is that? How do we judge that?
So one sign, like Ali was also saying, if you find some colleague, so again, word empathy comes in. Empathy simply means not sympathizing with somebody. It's like feeling emotion and still keeping a sense of detachment so that you can help the person. So if you feel some colleague, people have to be trained in that. Some biological empathy is natural. Like if you are sad and you even don't tell me, I see your face, I also become sad. That is biological empathy. We all have it. But then empathy is totally trainable stuff.
Yeah.
Those exercises should be done in close groups, like the places where you work. That if you see any of your colleagues, like somebody, Yash mentioned in between that you see somebody and you see that face is down and say, "Kya hua bhai?" So every time you can't ask, "Kya hua bhai?" If you ask 3 times in a row, the other person says, "Shut up, it's none of your business." So you don't want that answer. But keep an eye if you are feeling that somebody is behaving abnormally, slipping in duties, the usual level of alertness is not there, making mistakes, or withdrawn, or not talking, not for a few hours. If it continues for a day or two, suspect that there is something wrong. Right?
Okay.
That is the time when, and never ask that person in public.
True.
Then what is the problem? Never. Take out that person for a walk, for a tea, for something, call them by some alibi, and then check out. Chances are, if there are minor problems, they'll talk it out to you. If the person is not sleeping, not eating, or having crying spells, sadness, or even for that matter, agitation, that is the time you should not try to handle it yourself.
Sir, I think somebody rightly pointed out that as doctors, we are more of problem and solution oriented rather than process oriented. So,
Yeah,
yes, we should try to find out, we should try to talk
absolutely.
out, but then, we should timely and promptly should not shy away from taking help. And one more question, probably Dr. Binu, Dr. Chinu, or Dr. Yu and Dr. Alim can also answer this. Like, what is this? Is cognitive behavior therapy? It is becoming a very trending, so to speak, therapy. So, what is the role of cognitive behavior therapy in this kind of health problem?
Chinu,
Dr.
go ahead.
Pankaj has raised, yes, sir.
Uh,
Just
Sir, actually, I have just one comment to make. One thing is that all over the world, whenever these systems are made, which are made to run 24 into 7, like ICU, high stress environment with full efficiency 24 into 7, they were never designed to take into consideration the well-being of the nurses and doctors. They have never been taken care of. So the system exists. Now, problem is that our health system, especially in India, is so scattered. If you go to periphery, there will be one anesthetist looking after ICU as well as the OT. So to expect here some colleague will notice, nobody will notice. So that's why I suggested that only thing can be done is, if it can be done, it's through the central society, and there are local branches everywhere, and they meet every week, and a network can be created, especially because if there is no system, where the person will go if he seeks help? He has no place where he can go. In Delhi, Chennai, these are very different cities. Rest of the India is totally scattered. One anesthetist in one city, two anesthetists in one city. So they have to have a system whom they can approach. So first thing is to make a system, at least they have some help in some way. That's what I have to say.
thank you. Because we are running short of time, we'll take the questions. Dr. Shikha and Dr. Sunil Karan will take the questions from the audience. At the end, I'd like to thank our psychiatrists and psychologists and intensivists. Sorry, Dr. Vignesh and Dr. Kole sir, I could not come back to you again. But we have to remember that critical care medicine is the only specialty where care comes before medicine. So we need to care for our own selves before caring for our patients. And every intensivist deserves the same vigilance and dignity we give to our patients. We are very diligent for our patient care. Line, if it is not covered, not lean, we make a huge cry. Survival is not only for those inside the ICU bed, but also who are standing beside the patients. So with these words, I'd like to thank our panelists, and I'll hand over to our chairpersons for further discussion.
Thank you, all of you. I'm just seeing if there are any questions in the chat box. Anyone is put?
So,
Just one
so if
30
you
second
allow, I'll
point.
just take Dr. Shikha's question and
Yeah.
just give her an idea in 30 seconds about what is CBT. So CBT, Dr. Shikha, is an umbrella term used for evidence and empirical based psychotherapy all over the world, where we have lots of different modalities, where in one kind of modality we have thoughts as the main phase of modification, where we say that there are negative thoughts, automatic negative thoughts, and let us examine them. Let us see how we can modify them and convert them into more rational thoughts. So Aaron Beck's CBT and Dr. Albert Ellis's RE-CBT fall into this category. But now we have more spiritual and wisdom-oriented psychotherapies in place, in which we have mindfulness-based approaches and acceptance commitment therapy like therapies, dialectical behavior therapy like therapies, which modalities focus more on accepting that life is painful, adverse, full of difficulties, challenges, and how can we still remain emotionally and mentally healthy by modifying our attitudes, behaviors, and allowing ourselves to humanly feel whatever we feel. Like Dr. Bajpayee talked about something called as nature, you know. Nature and universe has bestowed a lot of resilience in us. We need to take it, manifest it, we need to utilize it to its full potential to take care of ourselves and others. Thank you so much.
Sir, one actually 30-second point from me. Do not forget the medications. Rational use of medication is one of the most important things. We have not yet talked about it. If you're diagnosed, take your proper medications, because if you're taking antidepressants properly, if you need it, it is the old workhorse. It will have the maximum beneficial effect uh, in the least amount of effort. So if you're diagnosed, if you're having some issues, so please continue to take medications. Do not have negative attitude towards medication that these are addicting, toxicants, or all those things. If used under supervision, they're very safe, very effective, and life-saving. Thank you, sir.
Yeah, so we have a couple of questions, I think. I think the first I'll ask to Dr. Vignesh about body and mind detoxification, kind of, how do we detox? Is there any specific way in pragmatic terms? How do we look at detoxifying
Thank you, sir.
the
Thank you, sir. I just want to say a few things. I would like you, Dr. Yash, to add, or any other seniors to add. But there's a lot of buzz in the recent social media about something called intermittent fasting, sir. I don't know how much of it, how much of you believe and how much of it is science. But some of them say it kills cancer cells, it improves immunity, it fights metabolic syndrome, it improves our overall physical health. Some of them are advocating for it. I don't know, but I have tried it for a while and I feel better. And I think mind body subjective, sir. Some of them may like walking, some of them may like cycling, some of them may like swimming, or some sport activity which actually engages them and helps them to de-stress. So some physical activity in that form, plus or minus mindfulness, like Chinu ma'am said, like maybe breathing, breath holding practices might help, sir. Please add to it, sir. I just wanted to hear from the experts like you all, sir. Thank you, sir.
Like your own work, I think that is one important thing.
I'm a very radical expert. So what I'm going to say, if you feel like, you can please throw it out of window. One, the biggest fraud,
Fasting, sir.
biggest racket which has been unheard of human race is the food racket. Our body has been trained through what was available over billions, millions of years. Now, if it may suit some people, so simple food, physical activity, and you missed one very important word, Vignesh, which is the biggest detox. How to remain happy. That is the biggest detox. Just because we are not doing that happiness, just because we are not connecting to people, and we are not doing human investment, we are trying in that space, that gap, we are trying everything else. Like mindfulness. If you really ask Buddhist monks, some of them are my friends also, I can promise you, nobody knows. One, nobody knows what mindfulness is. And second, nobody knows how to teach it. Right? Now, Buddha, it all came from Buddhist meditation. But Buddha told a lot of other things also. All mindfulness is the origin from the modern version of which is Vipassana. Right? So the real meditation is very tough. Buddha achieved it in 6 years, and people want to achieve it in 60 minutes. Now the problem, I have no problem with all this. People are free to go to temples. People are free to go to the modern day spiritual gurus. There are a lot of them in South India also. There are more of them in UP. You choose what we want. My only question is, that nothing changes unless the thought changes, right? And the second is, whatever you do, if your belief system and your thought system is keeping you in harmony, it's all right, wonderful. Do whatever. You can go have 2 beers in the evening and be really chill, right? Yeah, you don't want to have that doesn't matter, do whatever. But if what you are doing is not keeping you in good harmony, and forget the bliss, in at least some sense of happiness and all, that is toxicity. And toxic,
Yes, sir.
toxic is a word which is a vocabulary which has come to us from United States of America. We in India are unnecessarily adopting the American model of happiness, which is totally based on material objects. It is written in their charter that the wealth is the source of happiness. We should not, and I'm again repeating, India had better ways of living. And I'm not a person who will go into traditions unnecessarily. I wrote a book called Life, Death, God, Biology to Mythology. I just wrote it exactly to counter these points. The reason is toxicity. What are we talking about in this country of 150 people, where on the road you are brushing shoulders with others? Can we feel toxic? Do we have a right to feel toxic?
I think we may have to conclude, sir. Sorry
Yes,
for that.
Dr. Bajpayee, just one word. And we know that so many gurus are there who are teaching meditation, and you say that it's not such an easy thing what can be achieved within a short period of time.
Yeah.
But sometimes this comes in my mind that even we also in our conference sometimes we are inviting somebody to speak on these issues. Why the doctors are not teaching meditation? Why the doctors are taking the main role to teach meditation? They can project about the scientific meditation, and the psychiatrists definitely can play a major role on this issue.
Yeah. Psychiatrists can do it. Doctors can. Who has a better focus than a surgeon? Who has a better focus? A cardiac surgeon has the best focus. What meditation expert can bring that focus in? The focus you have in your ICUs is much better than anybody else. No, but somehow I'll tell you, Saurabh, in one sentence, if Sunil allows me, all these Babas ask for irrational surrender to themselves.
Then why we are not doing something? And ultimately they have got enough people, and they are getting some power also. But why we cannot promote it?
We ask people to listen to us rationally. And the moment we ask people to think rationally, there'll be conflicts. There it is like you come, you give everything to me, and you'll be okay. Yeah, some of us can try it, become new age scientific gurus. You have competition from Deepak Chopra then.
Yes.
And your Coimbatore Baba, who is that? Who talks glib English?
Right, sir. I think we are running out of time.
Yes,
I'm sure we would have learned much more if we had more time, but I'm sure we'll try to see if we can organize another session on this very important sort of topic, which is something very close to all of us, which, as you all had rightly said, we probably largely ignore, which is self well-being. I think one word, yeah. Thank you, everyone. I think it was an honor to be hosting this whole session with so many experts. I mean, a lot of humble learnings that we all got, and I'm sure it will make our quality of life better. For all of us who are trying to make others' quality better, I think we need to have good quality life ourselves is what is probably one of the gist of everything. Thank you. I thank all the SVM panelists and for such an interactive discussion, which was almost like a free flow talk and gave no semblance of a lecture or a talk of concept. Thank you, all of you. Thanks, and have a good evening, please. Thank you very much.
Thank you.
Thank you, sir. Thank you so much.
Thank you very much.
Bye, Alim.
Thank you
Okay.
for the
Bye,
session.
Vignesh.
Yes, sir. Bye, sir.